Hello and welcome everyone. Today we'll be discussing the management of Staph aureus bacteremia or SAB. This is the guidelines from the IDSA. Staph aureus is highly morbid infectious syndrome recognized as a primary bacterial cause of global death. SAB exhibits significant variation in disease severity, ranging from patients swiftly recovering with appropriate therapy to those developing very severe complications such as multiple hematogenous complications or even endocarditis. Traditional classification of SAB is into either complicated or uncomplicated based on the host factors, clinical progression, and to guide treatment decisions. Recent expert discussions suggest a shift towards classifying SAB by the risk of developing complication, aiming to enhance diagnostic evaluations and treatment plans. Guidelines versus practice. Despite existing consensus guidelines for managing SAB, there is a notable discrepancy in the management strategies among adult infectious disease providers. So for all these reasons, IDSA has made these guidelines of how we should manage Staph aureus bacteremia. So we'll start with a case. It is a 35-year-old woman who has come with a history of abusing drugs, and she has presented with fever and blood culture has grown Staph aureus. So with this background, how would you evaluate this patient? So let's see how it should be done. So first is the initial evaluation. We should conduct a comprehensive history and physical examination to determine the source and the onset of symptoms. Check for risk factors like injection drug use, presence of indwelling lines, or evidence of any soft tissue or skin infection. Seek infectious disease consultation, perform follow-up blood cultures, utilize echocardiography to detect potential complications. So the next thing that we will discuss is in what situation should you go for a transesophageal echo. So transesophageal echo versus transthoracic. Transthoracic sensitivity for infectious endocarditis in SAB varies from 35 to 82%, with transesophageal consistently showing higher sensitivity. Transesophageal is preferred for detecting small vegetations, intracardiac abscesses, leaflet perforations, prosthetic valve involvement. Advances in the transthoracic technology, that is harmonic imaging, have improved its sensitivity, yet contemporary studies focusing specifically on SAB are lacking. Now, deciding between the two, the choice between the two should consider the pretest probability of the infectious endocarditis, the TTE quality, and patient-specific risk factors. TTE may be sufficient for patients with lower risk, characterized by nosocomial bacteremia, sterile follow-up cultures, absence of intracardiac catheters, non-dependence on hemodialysis, no clinical signs of infective endocarditis or secondary infection focus. Persistent positive culture indicates a higher risk of infective endocarditis and complication. So in what situation should we do this? The risk stratification should be done. Recent tools like positive, predicting, and VISTA scores aim to more accurately stratify the risk of infective endocarditis in SAB patients, with VISTA providing a higher negative predictability value for IE. For patients with very low risk, echocardiography strategy should not influence the outcome. Transesophageal, following a positive TTE, the decision to pursue TTE after a positive transthoracic hinges on whether the transesophageal finding could alter our treatment. If it is not, then probably we should not be doing this, particularly when my surgical need is based on the transesophageal. Historical data show that transesophageal superiority in detecting complications like cardiac abscesses and leaflet perforations not seen in transthoracic, highlighting the need for more updated trials. So when and how frequently should follow-up blood cultures be sent? The significance of a positive follow-up is that a single positive culture after initiating the treatment indicates poor prognosis, with the risk of mortality increasing each day the culture remains positive. The 2011 guidelines recommend conducting additional blood cultures between 2 to 4 days after starting therapy, with further cultures needed should be sent as needed, although there is no definitive study on the optimal timing and frequency of these follow-up cultures. It is a common practice to stop performing the blood culture once they show no signs of infection, but the occurrence of intermittently negative results before fluid clearance, that is the skip phenomena, can affect decisions regarding the reimplantation of cardiac devices and intravascular catheters. So what is the benefit of molecular testing for diagnosing and managing the SAB? Rapid multiplex PCR is now available in many healthcare facilities, and it directly is done in a positive blood culture sample, and its quicker pathogen identification and resistant gene identification is done. The advantages are the quick identification of the organism and the resistance pattern. A recent RCT demonstrated that the PCR, especially when combined with antibiotic stewardship interventions, resulted in a faster transition to narrower spectrum beta lactam with patient with methicillin susceptible MSSA. What is the benefit of molecular testing for diagnosis? The discrepancies and recommendations. Though rare, discrepancies between genotypic and phenotypic resistance determined can occur, prompting recommendations to treat discrepancies cases based on the methicillin resistance. Incidence of MAKE positive isolates showing phenotypic changes with methicillin susceptibility to resistance during treatment has been noted. Emergence of diagnostic technologies like new approaches of next-gen sequencing and serum biomarkers have been investigated for potential to predict more complex cases and those with metastatic involvements. These technologies may add value to the evaluation of the bloodstream infection but require more research before they can be recommended for routine usage. When should imaging be done? Means apart from the echo. MRI for spinal involvement in SAB. Contrast enhanced MRI is considered gold standard for diagnosing spinal involvement. The decision to perform an MRI is typically based on the clinical indication, with variations in the practice regarding whole spine imaging versus focused imaging in suspected osteomyelitis cases. In a study screening the total spine MRI revealed additional non-contagious sites of infection in 23% of the patients suspected with having single level osteomyelitis. Next imaging is controversies and considerations. The utility of transesophageal echo and PET-CT in diagnosing infective endocarditis and metastatic infection site involves balancing the potential benefits against the drawbacks such as the procedural risks, the resource intensity, and the chance of incidental findings. Now, the discussion on management strategies, including the removal of prosthetic material, use of long-acting antimicrobial agents, oral antibiotics, or step-down therapy, reflect the ongoing debates over the best approaches in various patient scenarios, highlighting the need for more high-quality evidence. The potential mortality benefits seen with the PET-CT in observational study has been questioned due to the biases such as immortal time bias, indicating a need for RCTs to ascertain these effects in actual SAB. Now, apart from this, the future direction should be on ongoing RCT aiming to evaluate the role of PET-CT in SAB, focusing on identifying the deep foci of infection rather than on mortality. This underscores the ongoing effort to refine the diagnostic and management strategies for SAB, with results anticipated to contribute valuable insight into the optimizing care for these patients. So coming back to our patient, this was all about the evaluation. We understood when should we do the echo, when should we send the cultures, and when should we do the imaging. So this patient's blood cultures were methicillin resistant Staph aureus, which remained positive after 5 days of therapy. The transthoracic and transesophageal did not demonstrate any evidence of endocarditis. Now, what treatment decisions might you consider in her case? So let's see what should be done. Treatment approach for MRSA. For methicillin-resistant Staph aureus, recommended antibiotics include vancomycin or daptomycin, with precise dosing crucial for efficacy. Despite ongoing bacteremia after 5 days of therapy, the absence of infective endocarditis evidence on echo, these medications remain central to the treatment. The duration and early source control, a treatment duration of 4 to 6 weeks, is advised for cases exhibiting high-risk features to adequately addressing the infection. Early identification and management of the infection source is essential component of effective treatment. Empirical beta-lactam addition in high MRSA areas. The decision to add beta-lactam therapy empirically to MRSA coverage involves considering the local prevalence of MRSA and the specific characteristics of the isolate. While beta-lactams show superior outcome to MSSA bloodstream infection, the early addition in MRSA has not demonstrated significant benefits over vancomycin monotherapy and may increase the risk of AKI as was observed in the CAMERA 2 trial. Now, considering empirical combination, the need for empirical combination, or that is vancomycin or daptomycin with a beta-lactam prior to isolate identification might be lessened with the availability of rapid molecular diagnostic tests, allowing for more targeted initial therapy. Given the potential risks such as AKI with the combination therapy, careful consideration is required when choosing empirical treatment, especially with the advances in the rapid diagnostic technologies. Now, what is the implications for treatment selection? The case underscores the importance of antibiotic selection based on resistance pattern and the need for ongoing reassessment of the treatment strategy based on clinical response and diagnostic findings. The approach of SAB, especially in MRSA, emphasizes the balance between effective antimicrobial therapy and minimizing the potential adverse effects, including the strategic use of combination and the integration of rapid diagnostics. When should you prefer anti-staph penicillin over cefazolin in MSSA? Now, the choice between anti-staph penicillin and cefazolin for MSSA remains a contentious issue. The penicillins are traditionally favored in MSSA endocarditis and CNS infections, primarily due to the blood-brain barrier penetration capabilities, though recent evidences challenges this view. The AHA guidelines recommend ASP as the first-line treatment for MSSA endocarditis with cefazolin as an alternative. ASP is associated with higher rates of adverse effects, more frequent dosing requirement compared to the alternative, making cefazolin a more appealing option for some clinicians. Now, cefazolin inoculum effect. Concerns about the efficacy of cefazolin arise with isolates showing that there is an inoculum effect which is significantly increases in the MICs observed under the high inoculum conditions. Despite this, an Argentine study highlighted cefazolin's limitation with the inoculum effect isolate, indicating potential mortality impacts. The efficacy comparison, that is recent study comparing if it is superior with cefazolin or SP, even in the light of the inoculum effect concerns, the observation data ongoing research aim to further explore these findings, including a French RCT which is comparing cefazolin to oxacillin in MSSA bacteremia. Current recommendation is that despite the controversy over the inoculum effect and the efficacy of cefazolin in certain MSSA infections, the favorable safety profile and supportive observational evidence leans towards cefazolin as a viable option for most MSSA bacteremia cases. The use of penicillin for penicillin-susceptible MSSA is not currently advised, but is under investigation in an RCT. Which agent and what dosing strategy should you use for definitive treatment of MRSA? Vancomycin remains the standard treatment, with 2020 guidelines recommending optimizing the dose to individualized AUC monitoring instead of relying solely on the TRL levels to balance efficacy and reduce the risk of AKI. Daptomycin is an alternative. The FDA has approved it for management of bacteremia. While approved at a dose of 6 milligrams per kg, higher doses, that is 8 to 12, may be more effective due to the concentration dependent activity, with some studies suggesting better outcome at higher doses without increasing any adverse effects. It is not suitable for primary pulmonary infection due to the surfactant inactivation. Which agent and what dosing strategy should be used? Ceftaroline for MRSA, no FDA approval for MRSA bacteremia, but has shown activity against MRSA by inactivating the PPB2A. considering in some case series and studies as salvage therapy showing similar outcomes to daptomycin, though not recommended as an initial monotherapy without further evidence. The next is ceftorobiprole. This is a novel cephalosporin active against MSSA and MRSA showing promise in the ERADICATE trial for treating high-risk complicated SAB, including right-sided endocarditis, demonstrating non-inferiority to daptomycin for overall clinical success at 70 days, though its role in initial therapy for MRSA needs further clarification. The next would be the linezolid and trimethoprim sulfamethoxazole, occasionally considered for MRSA bacteremia treatment but lack direct evidence for prospective RCTs for this indication. Not recommended as a first line due to significant clinical trial data and concerns about tolerability. Rifampicin and gentamicin routine addition not supported. Native valve infective endocarditis due to Staph aureus with controversy remains with the use of prosthetic valve endocarditis. When should clinicians change the antibiotic therapy for lack of response, and which agents should be selected? The response to antibiotic therapy. Persistent bacteremia after 7 days of appropriate antibiotic therapy for MRSA is suggested by the 2011 guidelines is concerning. Some experts advise attention to any positive follow-up culture as an indication to reevaluate the treatment. Clinicians often explore antibiotic switches or combination for persisting positive culture, reflecting a proactive approach to managing resistant infections. Now coming to the combination, synergistic activity has been observed in vitro between high-dose daptomycin, either ceftaroline or anti-staph penicillins. Daptomycin and ceftaroline combination used within 72 hours of index culture showed a trend towards lower 30-day mortality in the retrospective cohort, although limitations in the study design make a broader conclusion very difficult. Despite limited robust clinical evidence, the synergistic demonstrated in vitro and positive observational data support daptomycin and ceftaroline as salvage therapy for MRSA bacteremia, potentially offering an advantage over switching solely to high-dose daptomycin due to concerns about daptomycin resistance. When should clinicians change? Now, this is for MSSA. The approach to persistent MSSA bacteremia is less defined, with some recommending a switch to ASPs or high-dose daptomycin from cefazolin, or exploring novel combination like cefazolin plus ertapenem or nafcillin plus ceftaroline, although clinical evidence of these strategies is very limited. A recent RCT indicated that adding daptomycin to anti-staph beta-lactam did not improve the culture clearance or reduce the mortality for MSSA. The general consideration is to change antibiotics should be based on clinical response, culture result, and evolving resistant pattern, with timing of such changes, duration, combination, and selection of the treatment therapy remains unresolved. The selection of alternative or combination requires careful consideration of the patient's factors, synergistic effects, and the resistance profile. What controversies exist regarding the source control? Now, delaying source control is associated with worse outcomes, metastatic infections, worsened outcomes, and persistence of the bacteremia. Removal of the prosthetic material, that is, necessitates the removing the material which is not definitely identified as bacteremia, remains debated, particularly when the removal entails significant morbidity. Challenges with devices and prostheses. Determining hematogenous involvement in devices like pacemaker, prosthetic valves, and joints is challenging, with certain infections being more clinically evident than others. A study found a significant percentage of SAB patients with indwelling SIEDs developed device infections even without initial signs of pocket infection, highlighting the risk of bacterial seeding and significant AHA for device removal in occult SAB cases. Now, orthopedic prosthesis. The substantial portion of patients with prosthetic joints may develop periprosthetic joint infections following the SAB, often with subtle manifestation. Low diagnostic threshold, proactive measures like diagnostic arthrocentesis, or advising the patient with joint pain for the persistence of the prosthesis. PET scan can be done. The potential role in identifying such infection and focus is very important. Now, can oral or long-acting intravenous agents be used as a step-down therapy? The interest in alternative therapies that is rising due to the risk associated with prolonged intravenous courses. There is a significant interest in less burdensome alternatives such as oral and long-acting intravenous agents for step-down. Dalbavancin is currently being used. It's a long-acting lipoglycopeptide effective against both MSS and MRSA and presents an appealing option for Staph aureus bacteremia, particularly in patients who use drugs. Now, its extended half-life supports infrequent dosing schedules, which can improve patient compliance and reduce the hospital stays. Although a retrospective study showed promising outcome with dalbavancin, concerns about significant resistance and the need for further research on optimal dosing still remain. Now, what are the oral agents? The Sabato trial highlighted the potential of early oral step-down therapy to non-inferior to conventional IV. In low-risk cases, there is a growing evidence supporting partial oral treatment as a viable option, especially for high-risk SABs or patients who are on drugs, unable to complete the IV therapy with outcomes compared to complete IV courses. A variety of oral regimens are under consideration for managing infective endocarditis on patients who are taking drugs, although the best agent and combination is yet to be determined. Choosing between an oral and long-acting IV agent. Now, decision making on using oral versus long-acting IV agent for step-down therapy should consider individual patient characteristics, including preferences and clinical characteristics. Healthcare providers are encouraged to explore these alternative strategies for patients facing barriers to completing traditional IV therapy courses, emphasizing the principle that some treatment is preferred to none. Should be the duration? The current guidelines recommend 4 to 6 weeks, while recommending 2 weeks of uncomplicated cases. Now, debate is there. The standard minimum 2 week is questioned by some contemporary studies which argue that shorter duration might be sufficient for certain patients without increasing the risk of relapse or late complications. Ongoing research, the SAB-7 trial investigated whether 7-day antibiotic course is non-inferior to a 14-day. The SAFE trial focuses on patients with complicated MSSA infection, including those with native valve endocarditis, comparing 4-week versus 6-week therapy to ascertain the most effective treatment length for comparing patient outcomes. Now, anticipation in the future is result from these trials are eagerly awaited as they promise to provide evidence-based insight that would lead to updated recommendation on the optimal treatment duration for both uncomplicated and complicated SABs. What additional management strategy should be used here? Now, patients who are using the drugs with SAB often present a unique challenge that they are young, high likelihood of being homeless, prevalent substance abuse can continue after treatment also. The management of the withdrawal symptoms is important, so treatment for opioid withdrawal should be given. Address the withdrawal and pain effectively can reduce the incidence of reuse of the drugs, reduce overdose risk with treatment. The treatment of opioid use significantly lowers the risk of fatal overdose, and overdose deaths among the patients who are taking drugs with serious Staph aureus infection have surpassed the infection related deaths, particularly among those not completing the antibiotic therapy. The additional management strategy that can also be used, like shared decision making involving the patients in treatment, is key. Challenging assumptions about safety and feasibility of OPD treatment can be considered. Guidelines is AHA provides guideline for managing infective endocarditis in patients who are taking drugs, advocating for patient-centric approach to include a multidisciplinary team with specialists. Recommendations emphasize the need for compassionate, flexible approach to antimicrobial therapy to accommodate the unique need of these addicts, aiming to balance effective treatment with achievable and patient-centric care strategies. Multidisciplinary approach encompasses both the infectious disease and substance abuse of the patient, optimizing the treatment and giving a holistic care to them. So what does the future hold? Challenges in the treatment remain. While RCTs are being designed, it is difficult to conduct and they have a high cost. Specific requirements of trials are always there. Heterogeneity of SAB further complicates standardizing the study approach. Innovative trial design, the introduction of novel outcome measures like desirability of outcome ranks, quality of life metrics offer a way to enrich the trial results with insight into the patient experience, providing more nuanced understanding of the treatment impacts. The SNAP trial, that is the STAP Aureus Network Adaptive Platform Trial, leveraging an adaptive trial design, represents a significant step towards SAB research. Now, with enrollment starting in Feb 2022 and significant participation already, SNAP aims to answer the pivotal question regarding SAB management, such as efficacy of sorted trial, duration, strategies for addressing persistent bacteremia, and the role of PET scan in the diagnosis. Now, area of future research remain, that is the shorter antibiotic duration, the timing, the antibiotic changes, the PET scan, and the biomarkers. So this is the management algorithm. If you get a patient with Staph aureus bacteremia, first you do the minimum evaluation, that is history, examination, cultures, and a transthoracic echo. Based on that, you can do your additional examination, which will be in high risk patients. If the patient is low risk, then you can go along the guideline as given over here. This describes all the antibiotics as well as the source control. This can be used. This is similar to that. It just presents it in a tabular form. So there is evaluation, additional evaluation, the physical examination that needs to be done, management, the agents that can be used, the duration, the persistence, then what should be done, then the source control, which how it is to be done, and the comorbidities that needs to be assessed. So as far as this particular case was concerned, there was no metastatic sites were identified. The patient was initially switched to combination, that is daptomycin with ceftaroline. Her blood cultures finally cleared out shortly thereafter, and she was hospitalized and with the opioid withdrawal, and she had those withdrawal symptoms. Even though she was asked for opioid therapy, she did not take it, and on day 11 she pursued a self-directed discharge and agreed to receive dalbavancin as a harm reduction measure. She received one infusion of it in the hospital, and second 1 week after discharge. Thank you for your patience.